I'm very happy to present the third and last best practice of this conference on personalized medicine research and implementation from basic research to the patient. The theme is translational medicine in familial hypercholesterolaemia and from phenotype to genotype to treatment. So the introduction to the whole panel will be done by Mafalda Bourbon, who's the coordinator of the FH study at the National Health Institute in Lisbon, Portugal. And she and the panel will be talking about multiple aspects of translational medicine in a very important disease. So I will just hand over to Mafalda.
Good morning. Thank you, Astrid, for the introduction. I would like first to thank ICPerMed board for choosing FH as the best practice in personalized medicine. This is very important for FH to be here today. So this session will represent European collaboration in familial hypercholesterolemia. We are actually a very tight community, the FH community. Europe works very close together, but we work with everybody around the world. You can see here in this map that every country that has a color means that they have published mutations in one of the 3 genes causing FH. So it means that apart from Africa, you have FH studies going almost all over the place. And the shading depends on the number of variants that have been identified. And you can see that Europe is very active on FH studies. And actually, the UK and Netherlands were the first to start population studies. And we have here representatives from those countries. So we will start this session with myself, with the mechanism of disease and research effort. And then I will pass the floor to Eric Sijbrands. He's a professor of internal medicine at Erasmus MC in Rotterdam. And he was one of the fathers of the national screening program 30 years ago in the Netherlands. And he will speak about clinical studies and health system implementation. Then we'll have Steve Humphries, a professor in cardiovascular genetics at University College of London. And he has been the lead of several FH projects during these more than 30 years, and he's the lead advisor for the NICE guidelines for FH. Then we'll have Gabi Hanauer from Austria speaking about the patient benefit. And she's the president of the FH Patient Association in Austria. And she's also the project coordinator for the FH Registry and screening strategies in Austria. And we'll finish up with João Lavinha from the National Institute of Health in Portugal, my institute as well. And he will talk about ethical, legal, and social issues in FH. He's also my co-moderator for this session, so at the end, he will do a wrap-up of the session, and we'll open the panel for discussion. So, this is the panel constitution. So I'll be talking about the disease mechanism and research effort for FH. So for the ones here that don't know what's FH, I have just some simple lines here, because then Eric and Steve will talk a bit more the clinical side of FH. So FH is one of the most common, or the most common lipid disorder, and it's quite prevalent. You can see that it can go up to 1 in 250, and in the North European countries. And homozygotes are rare, but they are very, very severely affected. And the majority of the cases have mutations in the LDL receptor, but there's patients with mutations in ApoB or PCSK9 genes, and they are causing FH as well. These patients present very high LDL levels from birth. And it's quite amazing that being such a common disorder is completely underdiagnosed and undertreated all over the world. And I think this is probably due to the fact that cholesterol doesn't hurt, doesn't give you symptoms. So many patients are identified when they have a myocardial infarction. And this is actually the major risk for FH patients, is because they have a long life exposure to high LDL cholesterol, they develop very early premature coronary heart diseases. It can be in the first decade of life if there's a homozygote patient, or in the as early as late 20s, 30 if it's a heterozygote patient. But we can prevent these premature cardiovascular diseases in FH because there's accurate diagnosis and there's several treatments to reduce the cardiovascular risk. So the lipid metabolism, the major organ is the liver. So if you can imagine that this is a hepatocyte, you can see here the three main players, the LDL receptor, the ApoB, and the PCSK9. And you can see that the LDL receptor stays at cell surface and binds the particle of LDL that has an ApoB over it, and it's through the ApoB that binds the LDL receptor, and then the complex is internalized, and then here in the endosome is dissociated, the receptor recycles to the cell surface, and the particle goes to degradation for metabolic uses. So if you have a mutation in the LDL receptor gene, depending on the exons, you can have all these stages affected. If you have a mutation in the ApoB, you have a binding defective because the particle, cannot bind the LDL receptor. And if you have a PCSK9 defect, what happens is that the receptor does not recycle to cell surface because the PCSK9 binds very strongly to the complex and sends the whole complex to degradation. So we have more than 2,800 variants being described in FH patients in the 3 genes causing FH. The most common, like I said before, is mutations in the LDL receptor gene. But the problem is that half of the LDL receptor mutations are variants of unknown significance. And in ApoB and PCSK9, even higher, 80% of these numbers there are variants of unknown significance. So now we can identify easily variants, all kind of variants in these genes, but the difficulty is to interpret these variants. So some years ago, Stanford, Harvard, and North Carolina University started this huge project called Clinical Genome Resource. And the main aim of this project is to define the clinical relevance of genes and variants for use in precision medicine and research. So they form a FH variant curation expert panel, and actually Steve, Eric, and myself were invited to this panel with other around 30 FH specialists all over the world, but mainly from Europe. And we have 3 major functions in this group. So we needed to promote FH-associated variants to be submitted to ClinVar. It's a public database because it's very important that you share your results and you share the variants that are being found in FH patients. So that has been done and published. And now we are developing an FH algorithm to classify all variants, and this is ongoing, almost done. And in 2019, we are going to start to curate the 2,800 variants associated to FH. And this is going to be very important for the genetic and clinical diagnosis of these patients. But we can do more than that. We can do functional studies and characterize what is happening with the LDL receptor when they have the variants that we find. So we can actually determine expression, binding, and uptake rates. And you can see here some results from a lot of variants that we have characterized in my lab. And you can see that they have different profiles. And for example, here, you can see that these variants they have normal expression, binding, and uptake, so they are benign variants. They are not variants causing FH. These patients do not have FH, and the cause for the dyslipidemia must be sought and must be looked in other places. Probably these patients have other lipid disorder, or it's just that dyslipidemia is just due to environmental causes. So these patients need to be treated accordingly. Then we have the most severe patients having almost no protein. So these patients do not produce any viable LDL receptor, any functional LDL receptor from that allele. And so they are the most severe patients, and they have to be treated with every drug available for them to reduce their LDL values and their increased cardiovascular risk. So you have statins, inhibitor of intestinal cholesterol absorption, and you have the new PCSK9 inhibitors. So then, these are the most common variants. These are defective binding variants. And these patients present milder to severe phenotype depending on other factors. And they probably statin and an inhibitor of intestinal cholesterol absorption is enough to decrease their LDL values. Then we have another class here that's recycling defect, and these ones that you can see here that they have expression that is reduced as well, and we think it's because it's a recycling defect, but we need to study this further in the lab, and they usually show milder phenotype, and they respond very well to statins. But there's another diagnostic question that we have to tackle in the lab as well. We find more or less in 50% of the patients, we find a mutation causing disease, but there's another 50% of the patients where we don't find. They have a clinical phenotype of FH, so very high LDL values with a family history of very high LDL values as well, but they don't have a mutation in one of these three genes. So it can have multiple causes, but there's two causes that we can identify genetically. That's the polygenic hypercholesterolaemia or other monogenic causes. And actually, this has been incorporated in the last consensus paper for FH testing, and where we have actually said that if the patient has genotype positive and phenotype positive, it means that has a mutation causing disease and high LDL. So you should treat LDL according to the variant and the phenotype the patient presents. But if it's genotype negative, so no mutation found, but is a phenotype positive, so high LDL, you need to consider alternative causes for the disorders. And we have several here, and the polygenic that I have spoke, and the other monogenic disorders that can mimic FH phenotype, hypercholesterolaemia and the lysosomal acid lipase deficiency are very important because they need different treatments. So that's why we wrote in the recommendation that you have to treat a phenocopic condition with specific treatments. In the Portuguese FH study, we have done as all over the world. So we have started just looking at the LDL receptor and ApoB, and ApoB variants. Is not going. But in the recent years, we have starting to do the analysis of the polygenic hypercholesterolaemia, and we have started to look at other monogenic disorders. And we have, this way, we have increased our detection rate to 59% in children and 50% in adults. And this actually made us change our diagnostic test because we are just studying LDL receptor, ApoB, and PCSK9, and we, with the next generation sequencing, we can do much better. We can include other genes, the phenocopy genes and the polygenic score. So that's the test that we are offering now for FH, the 3 genes causing FH and 4 phenocopies and the LDL score. And this is, you can see here why this is important, because look at the slice of other monogenic disorders is greater, is larger than due to PCSK9, that is the 3rd gene associated to FH. So this is what we're doing, and I think all over Europe and all over the world, we are going to start seeing this happening, and the diagnosis is being improved, and we can identify many more patients like these. So now we have, this is what we have. We have a phenotype that is an FH phenotype. This is the clinical criteria for FH. And we know that the majority of the patients are going to have FH due to one of these gene defects. But we also know that are hidden in this phenotype patients with different disorders that I have spoke about, LALD, hypercholesterolaemia, this beta-lipoproteinemia, autosomal recessive hypercholesterolemia. And it is important to identify the correct etiology of the dyslipidemia, because these disorders have different treatments, especially LALD and hypercholesterolaemia, they are not treated with statins, and statins can actually worsen the prognosis of these patients. So just a last message, take-home message, probably this is true for many disorders, not only for FH. The identification and characterization of the gene defect is important to establish a precise and personalized diagnosis and treatment. And as being true for many disorders, what is the great advantage in FH is that we really can identify, interpret the variants, and characterize functionally these variants. So we can do the whole cycle for the allele receptor, ApoB, PCSK9, phenocopies. So there's my lab and other labs in Europe that can do this. So we are kind of advanced in this. So I just finished by thanking all patients and families and clinicians who collaborate with us, and my team that works very hard in the lab. Thank you. And I'll have Eric coming now to the stage to speak about clinical studies.
These are my disclosures. I want to address the Dutch nationwide screening program, and actually, to be honest, at the times when we did set it up, we didn't realize that we were performing personalized medicine. Not at all. And the secret of setting up such a nationwide program lies in working with a couple of friends, actually. There was no competition between institutes, and with the three of us, with the four of us, we did set it up. And then we had a good division of tasks. We did lobbying on our own, having meetings every 2 months on what we achieved. And so it was a very good collaborative action. And then Peter Landsberg left for Asia, living in Asia. And then Iris Kind came in, and actually she was the person who led this screening program, and most patients were screened then. So what I will tell you further about the disorder and I will show you how patients present themselves to the physician. And then, of course, I will answer all your questions about such a screening program. And if there's some place for improvement still. And I can assure you that there is. When do we think of familial hypercholesterolemia? Actually, as a physician, you should think about it when a patient arrives to your clinic with very premature coronary artery disease. But among them, it's only 10% that has familial hypercholesterolemia. Most patients are identified based on high cholesterol levels without other explanation, and mostly a clear inherited pattern in the families, but with the small families of today, that's sometimes missing, sometimes difficult. When we were setting up the screening program, we thought that this is not a really good standard way of approaching the patients. We should actually make a kind of scoring system, and you should realize that at these times, genetic analysis was still very cumbersome and expensive as well. So we were setting out for a method that is selecting a priori the patients that probably carry mutations. And that's why we also look for specific symptoms. Here you see a corneal arcus, which is pathognomic for the disorder when it occurs before age 45. And here you see the typical xanthomas, the thickening of the tendons. They're also pathognomic for familial hypercholesterolemia. Here you see it better, large xanthomas. And the patient is telling me, while he's showing it, that they reduced a lot during his cholesterol-lowering therapy. And in a moment, he will show you his Eckart tendon, It's very much inflamed. There's erythema. You see, it's very red. And his agal tendon is very much enlarged. So actually, without measuring cholesterol, you can now diagnose in the street or on the beach whether or not a patient has familial hypercholesterolaemia, at least a subgroup of them. But of course, the xanthomas are very interesting, but this disorder received so much attention due to the atheromas. And we calculated in a population-based manner that the odds ratio of getting coronary artery disease in our population is 8.5, having FH. And there are other analyses. In Japan, they estimated a much higher odds ratio, but probably there's some selection on outcome in that estimate as well. But what we also noticed in mortality studies, also population-based, is that there is a huge variation of the risk. Actually, the risk we know from the textbooks is seen in 60% of the families, while 40% of the families, untreated, reached a normal lifespan. So there's a huge variation, and I think that that's still, we devoted our work for the past 20 years to improve the prediction in that respect, but I think that we're now on the edge of implementing a better risk prediction within screening programs. This is the announced scoring system. Something about family history, of course, the personal history of cardiovascular disease, the symptoms I showed you, and of course the level of cholesterol is important. And then, if you have probably FH, 6 or higher point scorings, then we started to perform the genetic analysis. And actually, that's still how we do it. And if we've identified the mutation, then we start the screening of the family. This is a scoring system for adult index cases, and here you see that if the child is the index case, the first patient of a family, the algorithm is much more simple. If a child has high cholesterol and there's no other disorder, then the probability that it's familial hypercholesterolemia is very high, and we immediately start to perform genetic analysis. And then these genetic analysis, today we screen approximately 30 genes, but still today most mutations, 95% is LDL receptor related, 4% ApoB, and the others less than 1%. The next speaker will talk about polygenic risk score, so I will leave that for Steve. And then if we have the diagnosis, we will start cholesterol-lowering therapy, and the main treatment is statin treatment. But we have new drugs, so we can personalize the treatment as well. When we screen, this is a result from the screening program, when we screen and treat the patients with statins, these are the approximate residual risks. So we reduce the risk of coronary artery disease by treating these patients by values between 75 and 80%. But still there's a residual risk. It's small, but there's still some going on. And here you see that the same analysis, but now in the context of the general population. The blue line is the general population. That again, the untreated patients have also here in this respect a hazard ratio of 8.5, as we estimated previously. And the treated patients do not even have a significant difference with the general population anymore. So if you screen, you achieve early identification, you start treatment early, you normalize the risk of the patient. We, of course, to convince our government that we needed to perform nationwide screening program, we did some calculations about the cost effectiveness. And this is the old calculation we made when the statins were still under patent, when we used our expensive genetic analysis. And it was fair. At that time, the cutoff value, the acceptable cutoff value, was 25,000. So it's a good case for preventive screening. In the UK, they recently repeated such analysis, but in a much broader context, comparing all kinds of different screening strategies, screening the general population, screening starting from children, screening the way we do it, the cascade screening we call that. And they do it in times where the statins are out of patent, but they screen more genes than we did in the past. And there is a tiny bit of more expensive new drugs in it. But I think still, and the cutoff value today is 30,000 euro, still it is a good business case for the screening, in whatever way you do it. And I didn't show the outcome for screening children, but actually it's a bit more expensive, but still it's very much below the threshold. And then there's a recent paper from Spain, and there it seems much more expensive, but that has fully to do with the fact that in Spain they prescribed the new PCSK9 inhibitors, the new cholesterol lowerers, in a much higher frequency. So that makes your program more expensive, although it's still under the cutoff. But I think in general we need personalized medicine to keep these types of treatments payable. I think that we really need no guidelines made by industry. We need to make them ourselves and implement personalized medicine and use these expensive drugs better. Was this enough information for you to start a screening program for FH? Or are you missing still things? I will summarize it so far. So it causes severe premature coronary artery disease. Hypercholesterolaemia is not something you feel. There are no prodromes. If you do not screen, then there is, out of the blue, an event. There's good treatment available. There's good cost effectiveness if you do not use too much of these very expensive new drugs. I think that we achieved a lot. We've been working with internists and cardiologists mainly. If the GPs in the Netherlands would have embraced this screening program, we probably would have been ready with the screening right now. We're halfway. So that's the stakeholders are ultimately important, but actually today still we didn't manage to get the GPs very enthusiastic about it. And then a good thing is that the insurance companies guaranteed insurability, and actually our studies with regards to that improved the insurability of the patients worldwide. That shows, I think that's often a fear if you start to do omics, you start to study the genome, the proteome. People will say to you, well, I do not want to participate in it, in studies like this or healthcare like this, because I probably will not be able to get a mortgage. But that's wrong, actually. Our research improved insurability. And you can use our screening method as an example. And then we were lucky that we have a very strong patient support group. And actually the best lobby in the government was done by them. This is how cascade screening looks. It is not screening of families. It is screening of the population through large pedigrees. And of course, I show you my best example. This is 24 meters. I hope you still have time. And there are 2,400 patients in it. Of course, there is some, it stimulates some compulsive behavior, because if you are building a pedigree like this, you can't stop extending it. This is the history of our screening program. We had initially 10 years funded by the ministry, and then we did get an additional year, and actually we identified, between 40 to 50% of the FH patients in the Netherlands, using a high prevalence of 1 in 250. And then our ministry decided to put the FH screening in regular care. So in theory it's reimbursed, but actually regular care is a disaster for a screening program, because we are very transparent in all hospitals. We go to the insurance companies with exactly what we do, but the insurance companies pay all our hospitals a lump sum. And then within the hospital, you need to divide the budget. And in Rotterdam and Amsterdam, we're still screening, but in all other hospitals, they said, well, it's probably not that academic. We better do transplantations. So we don't sponsor this activity anymore. So being in regular care is also a danger. Actually, it doesn't work, and we're trying to repair that, but it's very difficult. It's very difficult. You end up in discussions where you actually don't want to be. You don't want to compare your patients. Each patient is a patient, and you want to do your very best for each patient, whatever disorder they have. So especially for the physicians, this is a difficult discussion. Try to stay out of that. So this is the countrywide screening result today. We are on our way. Approximately 35,000 patients identified today. But can we do better? I think so. There's a large variation, and there is still a residual risk. So we actually need to improve our risk prediction. We need better use of the new drugs, and we actually need to enhance our personalized approaches. Here you see a genomic risk score. We started off with 1 million DNA polymorphisms. And out of that 1 million DNA polymorphisms per patient, we identified 49,000 SNPs, polymorphisms, that predicted coronary artery disease very well. Actually, here you see our genetic risk score, genomic risk score. And here you see the Framingham Heart Risk Score and the ACC and American Heart Risk Scores. And you see it's a bit above them. Actually, it's predicting much better. And you should realize we can use our score just after birth, while for these scores, the traditional Framingham Risk Score, American Heart Risk Score, the score table in Europe, we need to wait until the patients are over 50 years of age. So from birth on, we can predict better than using these being patient and using these scores. And if you combine them, if you are patient, and you combine them when they turn 50, then you predict nearly perfect. And of course, a lot of people say, oh, you shouldn't do that. And actually, that's something you also hear when you do omics. Oh, you shouldn't do omics, because then you... actually, you are a fatalist if you are doing that, because you're showing that the patients have genetic disorders, and yeah, you cannot help that. But that's completely wrong. Actually, within these analyses, we noticed that low blood pressure, non-smoking, and low cholesterol, relatively low cholesterol, already were able to compensate for the high genomic risk score. So actually, if you do the genomic risk score very early in life, you can personalize lifestyle approaches on that. So I think that that's a unique opportunity to improve the risk of our patients and actually to treat them more elegantly than we're doing right now. And then actually we try to do all omics layers. In the proteomics layer, we found in our population beautiful thing, and we think that our vessels have sent out health signals. So here you see a group of patients with healthy coronaries, and they produce these signals, peptides. They're mainly involved in pathways that inhibit inflammation or inhibit oxidation. And if you have atherosclerosis, but you are still asymptomatic, then these signals are strongly reduced. But if you already had myocardial infarction, they're gone. So these are signals of health, not risk factors. Risk factors are interesting, but only when you are old. Risk factors have a likelihood of 3. So the risk of the patient needs to be very high to use them as a predictor. Predictors of health can be used in younger populations. So to conclude, I'm very positive about improving the risk estimation in our screening by adding a genomic risk score. And I expect that we can monitor the treatment better with functional tests, actually like Professor Bourbon just told us, by better defining what type of mutation you are carrying, but also by these peptides we identified. And I think that we will end up in a lifecourse approach where we perform a good DNA risk assessment early in life, start treatment, mainly lifestyle, perform functional tests to monitor what we achieve with our interventions. And then, of course, still there will be a tiny residual risk. And I think that a major problem still, but we are working on that in an 8 Health SkyCare program right now and in multiple PPPs to develop all kinds of e-health tools to support these patients lifelong and to monitor them better lifelong. Thank you for your attention.
Okay, can I have the next? There you go. Thank you very much. So I want to thank the organisers and Mafalda for inviting me to talk to you this morning. I also want to acknowledge that the funding for my research over the last 30 years has been from the British Heart Foundation. And this slide really just reiterates and reminds you of some of the things that Mafalda and Eric have told you. FH is common. We used to say it's a rare disease. It's not. About 1 in 250, 270, maybe 1 in 300 in most countries in Europe. So there's about 200,000 in the UK, maybe 2 million in Europe. It's very much underdiagnosed, except in Holland, where, as you can see, they've been doing a great job for 10 years. And it's very much underdiagnosed in young people because they haven't had a heart attack, they haven't had a cholesterol measurement, and those are the people that we need to find because those are the people who'll benefit most. It's an autosomal dominant trait, and that's why the cascade testing is so effective. If I have FH, I got it from my mum or dad, half my brothers and sisters, half of my children have got it. So if you simply find me, and test my first-degree relatives, which is really simple because I know them all and I talk to most of them, then you can find usually at least 2 more. If you're in Holland and you've got big families, it's even more cost-effective. This is old data, but about 50% of men with FH will have had an MI by the age of 50 if they're not identified and treated, and about 60% of women by age 60. And as Eric has shown, early treatment with statins is extremely effective and reduces CHD risk. We know that these drugs are very safe and effective, but many of the identified patients are not, they're undertreated, they're not reaching goals, they're not reaching the LDL lowering that we'd like, and that's a problem. And as you appreciate from Mafalda's talk, FH is a disorder of LDL clearance from the blood. Now, this is the criteria we use in the UK. Individuals have to have cholesterol over 7.5 or LDL over 4.9. That's exactly the same as in Holland. And then a family history of high cholesterol or early heart disease. And then if you have those, you're given the diagnosis of possible FH. And Eric showed you the stigmata of high cholesterol, and particularly if you have the tendon-xanthomas or an FH causing mutation, then you're given the diagnosis of definite FH. And just for completeness, I show you again the Dutch score, which Eric presented. So here's the pie chart for the UK. About 93% of our FH patients have a mutation in the LDL receptor, about 5% in ApoB, 2% in PCSK9, extremely similar as to Holland, but these proportions do vary in different countries. And what has happened in the UK as a result of the advances in our knowledge and the advances in the ability to do next generation sequencing is that all 7 UK National Health Service diagnostic genomic hubs will be offering DNA tests from early next year. They use next generation sequencing to capture and sequence the exons of all the interesting genes. They can handle 96 samples in one run. That's clearly very cost effective. Costs are now down to about £250 for an index case. Once you've found the mutation, you simply sequence that change. It's much cheaper, and now it's much faster. And the costs of these tests will be covered by the NHS from next April. And this is a major advance, because up until now, the lipidologist, the clinician sending the sample, has had to pay for it. And that's been a major problem in getting commissioners to pay for the whole patient care pathway, because clearly it costs much more to do a DNA test than to simply measure cholesterol. And the commissioners say, we can't afford all this fancy stuff. Let's just measure cholesterol. And we say, no, you've got to do it. Anyway, from next April, NHS England are going to be covering it, and that really is a major advance. So how well do we do? Mafalda's mentioned this, but if you go to your lipid clinic in your country, your local hospital, and say, right, let's look at 100 patients, about 2/3 of them will have possible FH, and about 1/3 will have a definite FH. And in the possible FH group, the detection rate is about 20 to 30%, which isn't bad. In fact, it's quite acceptable compared with other genetic diseases. So you find those number of people who are carrying an FH mutation. In the definite FHs, the detection rate is much higher, so that's the number you find. So as Mafalda mentioned, overall, we can find a monogenic molecular cause in between 35 to 50, maybe 50% of the patients. And the question has always been, what's going on in the rest? Because from a clinical perspective, they look more or less exactly the same. And we put forward this hypothesis back in 2013 that having a large number of common genetic variants that each raise LDL by a small amount could mimic monogenic FH. And by then, of course, the genome-wide association studies had identified a large number of genes, loci through the genome, which are associated with modest effects on LDL cholesterol. So we used the 12 that have the largest effect and that were the most common. We called these 12 SNPs, and we made what we call an LDL gene score. We compared the score in a group of mutation-negative patients from the UK compared to 3,000 healthy subjects, and the mean score in the mutation-negative patients was significantly higher than in the controls. Our conclusion from that was that when we looked at the data in detail, in at least 80% of the mutation-negative patients, a polygenic cause of their elevated LDL cholesterol is the most likely explanation. and now we've confirmed these results in samples from 8 other countries, including Holland, Portugal, Greece, and several others. So what this means is that only those with a detectable mutation in one of the genes that we've all talked about should be given a diagnosis of, if you like, monogenic FH, and the rest should be called something else. We've suggested they should be called polygenic hypercholesterolaemia, because that's what we believe is causing it. So why is this important? Well, the first thing is from a research point of view, because we all think that there must be other genes out there causing monogenic FH, but if you look for those genes in people who've got a high SNP score, you won't find them, because the reason they've got high cholesterol and FH is because they've got a polygenic explanation. And the 100,000 Genomes project in the UK is recruiting, as it says, it's doing whole genome sequencing in 100,000 individuals. And our clinical colleagues across the country have recruited more than 500 no mutation, low score FH patients, and we will soon have the whole genome data to be able to look at that. That's very exciting. It's going to save us money. We originally thought that we should be doing cascade testing in anyone who's got a clinical diagnosis of FH. And of course, in those with a mutation, 50% of their first-degree relatives will have FH. In the polygenic hypercholesterolemia, the number of individuals who have elevated LDL cholesterol is much lower, because it's not due to a single gene, it's due to the polygenes, and that effect gets diluted. So if you have limited resources, which we do, focus your cascade testing on the monogenic group, and that's what the NICE guidelines that were updated last year say. And most importantly, it's an issue about treatment. I will only show you one data slide that demonstrates this, but I could present results from a lot of different studies. Clearly, the monogenic FH have got the highest CHD risk and need to be managed by experts in lipid clinics using the best available drugs. The polygenic FH patients have much less severe risk of CHD and can actually be managed by statin treatment by general practitioners. And this makes the whole patient care pathway much cheaper and, of course, much more appropriate. So here's just one piece of evidence. This is a large study published in the States. They looked at over 20,000 heart disease-free controls and cases, and they did whole genome sequencing, and they found mutations in a large number of them. What I've shown you here is the results. So this is the spectrum of LDL cholesterol divided into quintiles. The odds ratio for heart disease in the lowest quintile is 1, and surprise, surprise, as your LDL cholesterol goes up, your risk of heart disease goes up. This is the odds ratio for heart disease in the individuals who've got the LDL, have got an FH causing a defect. What you can see is that within any stratum of LDL cholesterol, the risk of heart disease is between 2-fold to 4-fold, 3 or 4-fold higher if you've got an LDL receptor mutation. So what this says is, firstly, LDL is bad for you, and secondly, LDL that's caused by a mutation in an FH gene is much worse. And the reason we think of this is because of what we call the LDL cholesterol burden. This is the equivalent of smoking pack years. So it's what your LDL cholesterol is summed over your age. And what I've done here is set the threshold for clinical heart disease at the point where a 55-year-old non-FH person crosses it. And you can see that an untreated heterozygous individual crosses that at 35 years, explaining why heart disease occurs 20 years younger. In purple, if you start a high-dose statin at the age of 18, then you cross it at 48 years. So you've lost 7 or so years of healthy life. If you start even a low-dose statin at the age of 10, then you cross it at 53 years. You've essentially got as long a life expectancy as in the general population. So that's why the guidelines say consider statin by the age of 8 to 10 years. So here's the distribution of cholesterol. There's the diagnostic cutoff. You can get there by having a monogenic cause. You can get there by having a polygenic cause. And that lower heart disease risk means it's a paradigm example of using genomic information in precision medicine. So just a couple more slides. I've spent several hours on the internet looking to see what is being offered by companies throughout Europe and America. I hope you appreciate now that a commercially available test has got to have next generation sequencing for all those genes. It's got to have the LDL score. It's got to use the criteria which Mafalda mentioned for variant calling, and it's got to be done in a timely manner. The Bristol lab does that, and it currently charges about £400. So this is one from Colour. It charges £99, which is good. Saliva sample. It can be sent by a healthcare professional or direct to consumer. It looks at only 3 genes. It does report in a very rigorous way. The turnover is quite quick, and there's a follow-up of a genetic counsellor by phone. This is a company in Spain. You can see what it does there. It covers more genes. I haven't been able to find the price, and I've emailed them twice and said, how much does it cost, and they haven't replied. I don't think they're hiding anything, it's just, it's not there on the website. Then there's another one, this is from America. They just cover 3 genes, healthcare professional or direct to consumer. Cost, turnaround and coverage unclear from their website. And then there's another one here, they look at 4 genes, the 4 that we know about, $250. They need blood or saliva, done it in 2 to 3 weeks. And Centrogene, this is a company in Germany, and they do LDL or ApoB, and for some strange reason, GHR. I don't know why growth hormone receptors should cause FH. They don't really explain it. It just makes you slightly worried about how much they know about FH. Costs unknown. They put blood spots on a card and send it through the post, or they'll take blood, and they do a turnaround very quickly. So this is the last thing. In summary, there's plenty of testing companies around the world. I'm sure if I dug further, I could find even more. Many of the websites are unclear about their methods, their costs, their turnaround, and after-test counselling, and no company currently offers the 12-SNP score. So although there's a lot of interest out there, I think we've still got a way to go. I won't say we need regulation, but we need some clear standards about how this is done, and perhaps this is something that this organisation can take on. Chair, I'll stop there. Thank you.
Wow, what a conference. So interesting, and I'm very grateful to be here. Thank you, Mafalda, for inviting me and the organizing team. I will tell you about the patient perspective in familial hypercholesterolemia. So just to summarize what we just heard, familial hypercholesterolemia is a genetic disease with more than 2,000 identified pathogenic mutations. It is underestimated, it is underdiagnosed and undertreated despite effective and potent therapies and a Nobel Prize already in 1985 that described the genetic mechanisms of the condition, on which we also heard that leads to heart attacks and strokes if not treated, or may lead to heart attacks. But what is my axis? Why am I connected to familial hypercholesterolemia? Because I am not a patient. But look at this little girl. This is my daughter at the age of 2 years. And at that age, she was diagnosed with a severe heterozygous FH that was genetically confirmed. She has a very vicious mutation in the LDL receptor, and that vicious mutation caused her father a heart attack at the age of 33, caused her uncle a bypass surgery at the age of 38, caused her grandmother several heart attacks and bypass surgeries. Eventually, she died of it. Her father's family, in the time when there was no treatment, had either died in their 40s and 50s or had suffered severe heart conditions. So, will my little girl suffer a heart attack? I can tell you, I'm very optimistic now, she will not, because she was diagnosed early on, she's treated with targeted medication, she will have a healthy life. But did I know that at that time when she was diagnosed? No, I didn't know that. I was devastated, I was depressed, and I actually had bad conscience because I was healthy and my little daughter was not. So, I had to know more about this condition, so I founded the first FH patient advocacy group in the German-speaking countries in 2004, which later became 2 potent patient organizations in Germany and Austria. We wanted, because of legal reasons, we wanted to have 2 patient organizations. However, we cooperate very closely, which is very important. So I think I can skip the next slides because we have heard so much about personalized medicine. I just want to tell you, I kind of prefer the term precision medicine because sometimes patients think personalized medicine is more like a better personalized relationship between physician and patients, which is absolutely needed and necessary, but however we know it is not. So I will, because of time, just skip the next slides. Of course, prevention. I mean, there's great hope that through personalized medicine will, in the long run, usher in a new era in the prevention of diseases and their secondary conditions, which is in the case of FH, of course, heart attacks and strokes. So, how can patient organizations add to personalized medicine and vice versa? I think a very, very important step is that clinicians, that patients, that scientists work together and form a powerful team. You have seen my colleagues here. We are the true United States of Europe because we've been working together for a very long time, and we are patients, we are scientists, we are doctors, and we've also become very close friends in the last couple of years. So, especially on ethical issues, I think patients, for instance, when it comes to the protection of sensitive data and strict data protection laws, like it is the case in Austria, and I think in many countries of Europe, patient organizations can add valuable advice. And it's the patients that can best claim patients' rights vis-à-vis stakeholders and health authorities, and they should claim their rights. Empowered patients can raise awareness of their own conditions. And so patients do have a very important voice and should use this voice. For instance, when it comes to claiming screening programs in their countries or free genetic testing. And of course, there are the registries, and through registries, patient data can be evaluated in favor of patients' optimal treatment according to their genetic profile. We also have an Austrian FH Registry, and I'm coordinating that right now, and we have currently the data of approximately 400 patients, but in the long run, I hope that this, of course, this number will rise much more. So I just summarized this. And now I tell you what we in Austria do, what we patients do to raise awareness of the condition. We reach out to the media. I think this is to the public and to the media, which is very important. We have press conferences, and we also participate in events. For instance, last May, we participated in the Austrian Women's Run, which is a big event in Vienna. And speaking about patient testimonials, you saw the picture of my little girl in the beginning. Now you see her again as an almost 18-year-old woman. She will turn 18 next Sunday. And this article on FH was published 2 weeks ago in Austria's biggest daily newspaper. And she and another 8-year-old girl served as patient testimonials, and I think they did wonderfully, and we need much more of such patients that are willing to talk about their conditions. We also, what we do, we liaise with politics, with politicians, health politicians. For instance, you see a picture here that was taken in the Vienna City Hall, and the FH Awareness Day 2015 was supported by the then Viennese City Council for Health, and you see these girls here with their mothers. They all have FH, but they're all diagnosed, they are treated, and they will not suffer heart attacks. I'm convinced of that. So we also had an FH Awareness Week in 2016 that was supported by 2 Tyrolean health politicians. One also had her cholesterol tested at our cholesterol check stand that we had in a big Austrian shopping mall. I already told you we participated in the Austrian Women's Run, and that was supported by the new Viennese mayor and an Austrian MP and former minister. We also launched our second FH symposium recently on November 6 in Vienna. I'm very proud of 8 patient testimonials. The youngest one was 2, and there was another one at 8 and one at 15, and they really did a great job and tried to convince the Austrian health politician that was participating, and he promised us to support screening efforts and genetic testing. We will see if that happens. I do hope so. And we also had an excellent speech on personalized medicine. Well, just a word to international cooperation. I already mentioned it before, but there is also an FH Europe, the European FH Patient Network, which I'm part of. I'm part of the board, and of course, personalized medicine is a priority there as well. Last but not least, I really would like to make you aware of a relatively new platform, the Austrian Platform for Personalized Medicine, a national networking platform that aims to sustainably connect all relevant stakeholders. They formed in 2017 and had their second annual conference only recently in Graz, in the city of Graz. They comprise 4 working groups. I'm part of the Society and Ethics Working Group together with other stakeholders and patient organizations. And currently, this Austrian platform has 116 personal members. They will, of course, rise, and 12 member organizations. Among them, as important institutions, is the Medical University of Vienna, Graz, and Innsbruck, Open Science Institution. And I'm sure this platform will also help to get a much more patient benefit in the long run in personalized medicine. And with this, I thank you for your kind attention.
Hello, good afternoon. So to complete this large round around FH, I will address some of the ethical, legal, and social issues as Mafalda has announced before. So this is the promise of precision or personalized medicine, whereas in the traditional medicine, everybody would be prescribed with the same therapy, so many of the patients would not benefit or even had experienced adverse effects. With the precision medicine approach and by the way of DNA testing, hopefully no adverse effects would happen, or no futile use of treatments would happen as well. So this is the promise. However, we all know that the drug response and in general health depends on many other non-biological factors. As I have pointed out in this diagram, you see that the environment plays, either the physical or the social economic environment plays the major role as a determinant of health, but also the organization of services, as we have seen this morning, especially in this panel, how important is how the health services are organized to to provide to the right persons the right interventions. And of course, the behavioral aspects of disease determination or drug response are also very important. So with this in mind, of course, and whereas the genetic makeup is not, for the moment at least, modifiable, all the other determinants are. So now, going back to the Portuguese experience that Mafalda has outlined in the first intervention, I will go through some of the issues and what has been our practice so far. So, whereas worldwide less than 1% of FH patients have been identified, although the disease meets the WHO criteria for large-scale screening, as the Dutch example, of which the Dutch example is probably the best example. In Portugal, with a very simple genetic test, as Mafalda told us, just using 3 genes, a very small panel for the moment, the 3 genes pointed there, but even with such a simple genetic test, around 44% of the expected cases have been identified. This is to be further improved by a gene panel sequenced by NGS, and of course, by improving also and setting up an infrastructure for the interpretation and communication of incidental findings that may come up with the widening of the genetic testing. Once the affected pathway is determined and characterized, the patient can benefit of a more precise mechanism-based therapy, as was pointed out earlier on this morning as well, although with some caution, of course, that we should not entirely abandon the organ or tissue-specific disease and transforming it into a mechanism-based phenomenon, or even, as Mafalda sometimes say, genotype-determined phenotype, because phenotype is, of course, the result of much more than the genotype. And, of course, the importance that of, as pointed out by our Austrian colleague, the importance of a patient registry. And in our country, we are embarking in that activity as part of an ongoing international initiative. So, to me, what are the lessons learned from this experience? So, beyond the individual's genetic makeup, the protection of or the restoration of individual health results from other things rather than just the genetic makeup, of course, like the so-called structural transformations affecting the population as a whole. The lifestyles, the social class, ethnic background, gender and sexual identity, the physical environment. But if we achieve this lipidemia control, and it's very interesting that one of the colleagues pointed out that even with an adverse genotype, if you have low blood pressure, low cholesterol, and another modifiable behavior corrected, you compensate for the worst genotype. So this lipidemia control, including in FH, is particularly susceptible to the structural factors above, I mean the modifiable genetic determinants of health. Of course, genomics is a tool, but in an expanding arsenal, not to be used in isolation. This is very important. And as somebody also this morning, I suppose, if I recall well, told us epigenetics should be part of these gene-environment interactions. And I was very pleased to know that one of the prizes that has been given by this consortium relates to the interaction between epigenetics and signaling pathways, which I think it's very, very appropriate. Although genetic services and screening programs aim to improve the health of the population, there is growing concern that the increasing number of genetic tests becoming available at lower costs could compromise the viability of the healthcare system. As Steve also mentioned regarding the UK case, now they have convinced the payers, I mean the NHS, to sponsor these kind of tests, but for many years the question was, would this be, can we afford this without compromising other health interventions? So to me, establishment or assessment of clinical utility is mandatory before any test, this or any other, is reimbursed. And finally, not everything is solved, of course. In spite of the Portuguese NHS being universal, general and virtually free at the point of care, many health inequities remain to be solved by improving other policies. And I have just mentioned some, with some impact on this kind of condition. So these are just my brief messages, and I suppose that I have now another task, yes?
Yes, I would like to ask you if you could do a wrap-up, because I think we are on time. So we'll, if you, João, could do a wrap-up of the session, and we'll see if the chair, if we can do one or two questions to the panel or not.
Okay, so during my brief presentation, I have already alluded to some of the points that the members of this panel have referred to, but now to wrap up, as you propose, I would like to call your attention to just a key idea from each of the previous presentations. Mafalda called our attention to the importance of establishing the molecular basis of each case of disease, and concurring with what Steve Humphries also pointed out, about 50%, so half of the cases are not solved by a monogenic model. So we have to consider polygenic models, and how poly would be the model. 2 genes, 200 genes, and we have examples in human pathology of extremely heterogeneous, genetically heterogeneous conditions. So this might be an interesting topic to investigate how diverse would be the spectrum of genes involved. Eric's presentation was very convincing in making the case for a cascade screening program. It is really impressive, and it's not a surprise that he has been invited as the voice of the best program worldwide in this case, to this respect. And finally, I would strengthen or underline the testimony from Gabriela regarding the importance of advocacy and international cooperation in the patients, from the patient's perspective. And also, she didn't mention that, but it was between the lines, the importance of involving the patients and their families to co-produce their own health. And I think this is a major role that the patients' organizations have in this kind of pathology, but in many others, also in the rare diseases, for instance. And that's it, more or less.
We have...
Well, thank you so much to the speakers, and I open the floor to questions from the audience.
No. Oh, yes, now it's working. First of all, I'd like to thank the ICPerMed conference for inviting me. I was invited from Canada as a patient advocate, and I really appreciate this opportunity, and I actually appreciate finally an opportunity to say a few things about that. Mafalda raised an issue that I think is very important, and that's the issue of the way I'm not sure this was his focus, but this is something important to me. He made the comment about using innovative, expensive drugs in some cases where probably they are not necessarily needed. And I think that one of the issues here is the way trials are actually created and the primary and secondary endpoints in those trials. And one of the things that we're pushing for a lot, at least in Canada, is disaggregation of data in trials so that they don't become all-comer trials, and that we actually do try to find the populations in which those drugs will actually be successful and save money in the system. And I think we should be pushing for much more of that, which leads me to my second point, which relates to some of the comments Gabriela made. I agree with everything she said about the role of patients. There are also sort of those of us who can think of ourselves as patient health policy advocates, and that is a systemic role. And I think that you should consider very seriously the engagement of us in the development of your clinical trial protocols, because we understand how to get them not just through regulators, but also through health technology assessment tools. We'll be able to help you find real-world data that you're going to need. I think we also can help you with social determinants of health, which I was very happy to finally hear after 2 days as being an important impact on health, as well as all the way along the continuum. And we're very big proponents of prevention, which is often left out of the continuum, and I think we'd like to help you with the advocacy there. So I guess my point is, treat us as partners, both individual patients who understand the disease, but also those of us who work with our governments and our systems. I think you need us, and we really need you. So I hope that perhaps your organization will think about that in the future.
Okay, it was more a comment, I believe, than a question.
We don't know what you mean by disaggregation of the data. Can we deal with it over lunch?
Okay, thank you. So there's another question here.
I wonder whether there is a big jump from the monogenic to the polygenic. And so my question is to the biological and genetical background of that. Between that is the oligogenic, and at least the degenic and the trigenic are nowadays feasible, I think. Well, a model implying a large number of genes, each with a very low contribution, adding up, I beg your pardon, linearly, is from a genetic point of view not really attractive. The theory behind that is 20 years old, the expectations. And it has been put to work since 16 years or so. I know that the motivation could be the technical feasibility. That is a road which is much traveled. But you probably know the verses or the poem by Robert Frost that it may be better to go the less traveled road. So the question is, why not look into the oligogenic in a possible oligogenic models?
Again, I think I'm going to discuss that with you over lunch. But I would suggest you read our Lancet paper, because a lot of the issues you raised there are detailed in a great deal. I'll make one small point, which is that in the Lancet paper, we also looked at a large group of FH patients where there was a mutation, and we looked at their polygenic score, and it was intermediate between the healthy people and the no mutation group. And our interpretation of that is that even when there's a monogenic cause, the polygenes are contributing, so that they're adding a little bit. So someone who, if you like, sticks their head above the parapet is, I've got a disease, there's a polygenic underlay, and then the monogene pushes them up. So, of course, it's a contribution from a number of different genetic sources.
I would like to add that actually the polygenic and the oligogenic approaches are not that different. In the individual patient, it's always oligogenic, but in the population, it's a polygenic thing, because each patient has his own variant.
The difference is in interaction.
Again, let's deal with that overlap.
Okay, any other questions? There's a question over there.
Thank you. This has been a wonderful day and a half. Yvonne Bombard from the University of Toronto, Canada. Thank you also, echoing the invitation to participate. One of the themes that were actually interspersed throughout a lot of what we've heard over the last day and a half is actually one of the underlying unintended benefits, potential consequences of using next generation whole genome or exome sequencing is the generation of and communication of incidental or secondary findings. And I've heard a bit of, from this panel and earlier, of the disclosure of these findings. So first question is, do patients have the choice around which of these findings they will learn? How do we actually mobilize shared decision-making in this space? Questions around e-health tools and decision aids will be very pertinent as we move towards not only making sure that patients are aware that they're going to be learning all of these extra unrelated findings, but how to actually then mobilize and activate positive use and avoid misuse, unnecessary health service use. And just to make a selfish plug, work that I've done from my lab actually is trying to identify and create and test novel e-health decision aids. It's an app called Genomics Advisor. So I would, it's also been tested through randomized control trials, so I would urge some of the work that we're doing in the personalized medicine action space to be thinking about how to leverage the e-health digital platform and move it into the genomics space more generally. So I'd love some more feedback from this panel on what some of the practice and policy and tools that you might be using to motivate and mobilize patient shared decision making.
Eric, I can just start. At least in Portugal, we are offering targeted sequencing for these lipidemia genes. So they are offered, the patients are offered the results about all the genes that we are studying. We are considering to study more genes in the patients that are genotype negatives. And in those, we have legislation that if we do exome or genome studies, we need to ask the patient if the patient wants to be informed of only the genes that are associated with the disorder or the whole genes. Of course, it's a bit impossible to interpret all the results we got from an exome or a genome, but we follow the American College of Medical Genetics recommendation to give a result on the 59 actionable genes. And so the patient will have to, when we go into those genomic approaches to find novel genes and or novel causes, the patient will choose which results they want to receive.
Yeah. I think I can add to that I fully agree that actually the e-health and the molecular methods are complementary, and the more intricate your basic analysis become if you add genomics to your diagnostics, if you add proteomics, the higher the need is for automated systems and self-management systems. Actually, without these systems, you cannot use your data to the full extent. Fully agree with you.
Okay, so one last question, okay? Just one last question. Then we have to move on.
And a short one. So isn't the problem that in the common diseases, omics has really delivered close to nothing? Isn't the problem the disease definitions that we have? I mean, in Lancet, Lancet has been a paper last year that we should not use the disease term asthma, for instance, because asthma is at least 4 entirely different diseases that just have a similar symptom in the bronchial tract. Or hypertension, for instance. If we keep on doing genetics or omics on disease definitions like hypertension, which are basically symptoms, but may actually be a symptom of 10 completely different disease mechanisms, I think we will keep on ending nowhere in common diseases or polygenic. So don't we need this change in medicine that we really acknowledge the fact this, what you said, mechanism-based disease definition is actually the key. We have to leave organs, we have to leave symptoms, we have to completely redefine what a disease is and basically redefine medicine.
Yes, we agree.
Okay, so I'm going to thank so much the panel for this wonderful contribution and for being such a trans-European panel, which is a novel dimension.